Welcome to LPN Launchpad, where future nurses take off. This is your quick review on prioritization and delegation. Why this matters. Coordinated care is the single largest category on the NCLEX-PN, 21% of the entire exam. That's bigger than pharmacology, bigger than safety, bigger than any other category on the test. And inside coordinated care, the questions students consistently call the hardest are prioritization and delegation questions. Not because the content is complicated, but because these questions don't ask you to recall a fact. They ask you to make a judgment call, the same way you will on the floor. Today we're building the decision-making framework that gets you through those questions, and through your first shift as a licensed nurse.
What is clinical judgment? You already met this in the nursing process and clinical judgment episode, so this is a quick refresher. NCLEX-PN defines clinical judgment as the observed outcome of critical thinking and decision-making, an iterative process that uses nursing knowledge to size up a situation and pick the safest, most effective action. It has 6 steps: recognize cues, analyze cues, prioritize hypotheses, generate solutions, take action, and evaluate outcomes. Prioritization is step 3, and it's the step most NCLEX questions are actually testing, even when they don't say the word priority. The number 1 rule: assess before you act. Before we get into frameworks, one rule that resolves more NCLEX questions than any other. When an answer choice list has both an assessment option and an intervention option, and nothing tells you the situation is a full-blown emergency, assess first. You can't safely act on a problem you haven't confirmed. The exam rewards nurses who gather more data before jumping to a fix. It penalizes nurses who intervene on an assumption. Framework 1, the ABCs. The first and highest-ranking framework is the ABCs: airway, breathing, circulation, in that order. If a patient's airway is compromised, that patient outranks everyone else on your assignment, full stop. It doesn't matter how sick anyone else is. No airway means no breathing means no circulation, so you always work top-down. This framework overrides every other framework on this list. If you're ever stuck between 2 frameworks giving you different answers, ABCs wins. ABCs in action. Example, you're assigned 4 patients. One has a request for pain medication rated 7 out of 10. One has new onset stridor and is anxious. One needs a routine dressing change. One is due for a scheduled antibiotic. Stridor is an airway sound. That patient could be losing their airway right now. Pain matters, but pain doesn't kill someone in the next 60 seconds. Stridor can. See the airway patient first. Framework 2, Maslow's hierarchy of needs. Once airway, breathing, and circulation are not in immediate danger, Maslow's hierarchy of needs takes over. Lower-level needs get met before higher-level needs. From the bottom up, physiologic needs: oxygen, nutrition, elimination. Then safety and security, protection from harm, freedom from fear, then love and belonging, then esteem, and at the top, self-actualization. A physiologic need almost always outranks a psychosocial one when both patients are otherwise stable. Maslow in action. Example, one patient hasn't eaten in 12 hours and is asking for their tray. Another patient says they're feeling isolated since their family hasn't visited. Both are valid concerns, but hunger is physiologic, isolation is love and belonging. The physiologic need gets addressed first. That doesn't mean the second patient's concern gets ignored. It means it isn't first in line. Framework 3, acute versus chronic. Next, acute versus chronic. A sudden, new, or worsening change always outranks a stable, ongoing condition, even if the chronic condition sounds more serious on paper. A patient with well-controlled chronic heart failure, who is at their baseline, is lower priority than a patient who just developed a new onset of confusion, even though heart failure is the bigger diagnosis. New and changing beats old and stable. Framework 4, actual versus potential problems. Actual problems, something that is happening right now, generally outrank potential problems, something that could happen. The one major exception: if the potential problem is airway, breathing, or a rapidly life-threatening complication, it can outrank a minor actual problem. A patient with a documented latex allergy and no current reaction is a potential problem. A patient who is actively vomiting is an actual problem. See the actual problem first, unless the potential problem is about to become a code. Framework 5, Unstable versus stable. Last framework, unstable versus stable, and this one trips people up. It's not about whose numbers look worse on paper, it's about direction. A patient whose vital signs are trending in the wrong direction, even if they're still technically within normal limits, is a higher priority than a patient with an abnormal but unchanging chronic baseline. Trending matters more than a single snapshot. Putting it together. Here's the full decision order stacked together. First, rule out an ABC emergency. That always wins. Next, look for unstable or acute changes. New and worsening beats old and stable. Next, actual problems generally outrank potential ones. And once none of those are in play, fall back on Maslow's hierarchy, physiologic needs before psychosocial ones. Work through this order like a checklist, and most prioritization questions untangle themselves. Practice. 4 patients, who first? Try this. You're assigned. Patient A, 2 days post-op, stable, requesting a warm blanket. Patient B, diabetic, blood glucose of 58 and shaky. Patient C, chronic COPD at their baseline oxygen saturation. Patient D, due for a scheduled dressing change with no signs of infection. Patient B is an acute, actual physiologic emergency. Hypoglycemia can rapidly progress to loss of consciousness. See patient B first. Everyone else can wait. None of them show a new, acute, or life-threatening change. Now, delegation. Prioritization tells you who to see first. Delegation tells you who else can help you see them all. This is the second half of coordinated care, and it's just as heavily tested. What is delegation? Delegation is transferring the responsibility for performing a task to another qualified person, while you keep the accountability for the outcome. That last part matters. When you delegate, you don't hand off responsibility for making sure it's done safely. You're still accountable for choosing the right person for the right task. Delegation versus assignment. Quick distinction the NCLEX likes to test. Assignment is giving someone a task that's already within their normal job description. An RN assigning routine LPN level care to an LPN is an assignment. Delegation is handing off a task outside that person's usual scope to someone qualified to do it under supervision. An RN delegating a specific task to unlicensed assistive personnel is delegation. Same idea, different word depending on who's receiving the task. The 5 rights of delegation. NCSPN and the ANA both frame safe delegation around 5 rights: the right task, the right circumstance, the right person, the right direction and communication, and the right supervision. Miss any one of these and the delegation isn't safe, even if the task itself was simple. The 5 rights, explained. Right task. Is this something that can legally and safely be delegated at all? Right circumstance. Is this specific patient's situation stable enough for the task to be delegated right now? Right person. Does the person receiving the task have the training and competency to do it? Right direction and communication. Did you give clear, specific instructions, not vague ones? Right supervision. Will you check in, monitor, and be available if something changes? All 5, every time. What can be delegated to unlicensed assistive personnel? To a nursing assistant or unlicensed assistive personnel, you can generally delegate tasks that are routine, standardized, have predictable outcomes, and don't require nursing judgment. Vital signs on a stable patient, assistance with activities of daily living, ambulation, intake and output measurement, and repositioning. These are tasks where the thinking has already been done, the plan is set, and the task is following it. What cannot be delegated? You cannot delegate anything that requires nursing judgment, assessment, teaching, or evaluation. That means the initial patient assessment, patient education, evaluating whether a care plan is working, care of an unstable patient, and administering medications. Administering medications is a licensed nursing task, not something unlicensed assistive personnel can do. If a task requires a nurse to think, not just do, it stays with a nurse. LPN/VN scope. What you can and can't do. As the LPN or VN, you sit in the middle of this chain. You can collect data, reinforce previously taught education, administer most medications, and carry out delegated tasks under supervision. What generally stays with the RN? The comprehensive initial assessment, developing the plan of care, initiating patient education for the first time, and administering high-risk medications like IV push drugs or blood products. Though exactly which tasks fall to the LPN varies by state, so always check your own state's Nurse Practice Act. When the NCLEX asks, who can perform this task, scope of practice is the deciding factor. NCLEX delegation traps. Watch for these traps. Never delegate the first dose of a new medication. A first dose needs a licensed nurse watching for a reaction. Never delegate an unstable patient, even for a simple task. Never delegate the initial assessment, even if it looks like just taking vital signs. First contact with a new problem requires judgment. And never assume a task is safe to delegate just because it sounds easy. Check the patient's stability first. Practice questions. Let's put this to work. 3 NCLEX-style questions on prioritization and delegation worked using the 5-step process. Understand the question, remove the distractors, identify the correct answer, eliminate the incorrect answers, and review the rationale. Question 1. The LPN is assigned to 4 clients at the start of the shift. Which client should the nurse assess first? A. A client 2 days post-appendectomy who rates incisional pain as 4 out of 10. B. A client with a new tracheostomy who is making high-pitched crowing sounds. C. A client with type 2 diabetes whose finger stick glucose is 110 milligrams per deciliter before breakfast. D. A client who used the call light to request assistance to the bathroom. The answer is B. The client with the new tracheostomy making crowing sounds. Step 1. Understand the question. This asks who to assess first, a prioritization question. Step 2. Remove the distractors. The exact pain score, the exact glucose number, and the call light request are details that don't describe an airway problem, so none of them change the priority. Step 3. Identify the correct answer. Only one option describes a possible airway obstruction, the crowing sound or stridor from a new trach. Step 4. Eliminate the incorrect answers. 4 out of 10 pain is mild, 110 is a normal fasting glucose, and toileting assistance matters but isn't life-threatening. Step 5. Review the rationale. Apply the ABCs. Airway beats everyone else on the assignment, no exceptions. Question 2. The RN is making assignments for the shift and has 1 unlicensed assistive personnel available. Which task is appropriate to delegate to the UAP? A. Reinforcing colostomy care teaching for a client being discharged tomorrow. B. Obtaining a set of vital signs on a client who is 4 hours post-operative and stable. C. Assessing a client who reports new onset shortness of breath. D. Administering a scheduled dose of an oral antihypertensive medication. The answer is B. Obtaining vital signs on the stable post-operative client. Understand the question. This is a right task, right circumstance delegation question. Remove the distractors. The exact medication name and exact discharge timing don't matter. Focus on what type of task each option is. Identify the correct answer. Vital signs on a stable patient are routine, standardized, and require no nursing judgment. Eliminate the incorrect answers. Teaching is always a licensed nurse task. Assessing a new symptom requires judgment, and administering medication is outside UAP scope. Review the rationale. Run it against the 5 rights. Right task, right circumstance, right person. All 3 hold up for B. Question 3. The nurse is reviewing morning assessment data for 4 assigned clients. Which finding requires the nurse's immediate follow-up? A. A client with chronic kidney disease has a potassium level of 5.9 milliequivalents per liter, up from 5.0 yesterday. B. A client with osteoarthritis rates joint pain as 3 out of 10 with movement. C. A client 2 days post-op has a temperature of 99.1 degrees Fahrenheit. D. A client with COPD has an oxygen saturation of 90%, unchanged from admission. The answer is A, the client with the rising potassium level. Understand the question. This tests trend recognition, not just which number looks abnormal. Remove the distractors. The specific diagnoses are background. What matters is whether each finding is new or unchanged. Identify the correct answer. A potassium of 5.9, trending up from 5.0, is both acute and actual, and hyperkalemia is a cardiac risk. Eliminate the incorrect answers. Mild, stable pain, a common low-grade post-op temp, and an unchanged COPD baseline don't represent a new or worsening problem. Review the rationale. Unstable and trending beats stable but abnormal every time. Recap. Prioritization. Rule out ABCs first, then unstable or acute changes, then actual over potential, then Maslow's hierarchy. Delegation. 5 rights, every time, and never hand off assessment, teaching, evaluation, or an unstable patient. Master these 2 decision trees and you'll walk into a huge chunk of the NCLEX-PN already knowing exactly how to think through the question. Thank you for learning with LPN Launchpad. Like if you found this helpful. Subscribe for